which was published in 2022, it's somewhere in between. We agree that in mild metaplasia, no surveillance is needed. In intermediate stage, we recommend 5 yearly surveillance. This takes reference from the GSAP data, which showed that the median time for development in stage 2, OGIM 2, was about 50 months, about 4 to 5 years. So the Singapore guidelines take reference from the GSAP study. So across these many guidelines, and actually I ran out of space, you can also add the American guidelines, but they are very similar to MAPS-3. I just quickly summarize what are the consensus, what are the differences. On the consensus, everyone agrees that high quality endoscopy,
Good morning. I am Shiv Sarin from New Delhi, India, and I have with me Professor Grace Wong from Singapore. This prestigious JGHFoundation APDWF Emerging Leader Lecture is one of its kind, and it's extremely prestigious lecture which is awarded after great scrutiny of the work and contribution of an individual. Both of us feel very privileged to chair this session, as the lecture is going to be delivered by none other than Professor Mark Muthiah. About him, I would like Grace to further give details.
Thank you, Professor Sarin. Good morning, ladies and gentlemen. On behalf of the JGHFoundation, it gives me great honor and pleasure to introduce the JGHF APDWF Emerging Leader Lectureship awardees, Professor Mark Muthiah from National University Hospital, Singapore. Mark is indeed my great friend. He graduated from the National University of Singapore. He subsequently undertook specialist training in gastro-hep and graduating as the top students in his cohort. So he also undertook further training in hepatology in Virginia Commonwealth University in the USA. So Mark has done a lot of amazing work in like advanced liver disease, liver transplantations, MASOD. His research has a lot of impactful in the field. So in fact, today we are so honored and privileged to learn from Mark about the progress of his research. So Mark, please.
Thank you. Thank you, and firstly, I'd like to thank my chairpersons, as well as the JGHF Foundation, as well as the APDW Federation for the privilege of having this award. I'm truly humbled to have this award. I'm also very grateful to the audience because I understand that Dr. Nagi Reddy is actually talking at the same time. So I'm really grateful to have everyone here in the audience. So I'm Mark. I'm one of the transplant hepatologists from Singapore and from the National University Hospital. And so I think firstly, the history of this award, and I will go through the history of the award. And I want to highlight 3 people who have gotten this award who've made a significant impact on my career in the past. And the first is none other than my mentor, Professor Dan Yok Yang, who won the award in 2014. His topic was the liver's holy grail on the somatic liver stem cell. And what is very interesting is I started my research career working on liver stem cells and progenitor cells with Professor Dan Yok Yang. And I'm very grateful to him, although sometimes I joke that he dragged me kicking and screaming into research. So then, how did he drag me kicking and screaming into research? When Professor Henry Chan came to Singapore and was our visiting MBBS examiner, he sat down with 2 junior consultants, myself and those of you who know Daniel Wong, and he basically gave us a lecture about e-antigen negative hepatitis B and his entire research career. And he triggered in us a passion for wanting to do research. The last awardee who has made a huge impact on my career is actually Professor Vincent Wong. And while I've never had the privilege to have worked with him and been mentored by him directly, I think he's truly an exemplary figure in terms of the science that he does, how to conduct himself as an academic clinician with honor, and most importantly, as a good human being. So, and I'm very grateful to him for having taken one of our team members, Shirley, to train with. So these are the three, and I think I'm very grateful to follow in the footsteps of these three people. So these are my disclosures, but I will have one more disclosure for my talk. I'll be bringing up some controversial points. These are my own views, and I'm happy to discuss this further. Please do not, as we say in Singapore, do a blanket party on me. Secondly, I'll be presenting unpublished data from my group. Please refrain from taking photos of my slides during the presentation. So firstly, this is the outline of my talk, and this is the view of how my group conducts its research. Basically, we find that there are a number of challenges in the current existing literature, which is kind of challenging our progress in NASH cirrhosis, and how we are trying to address all of these. So firstly, I think we have a graveyard of drugs that have failed in NASH cirrhosis. So I've summarized all the trials that have that we basically see that people have conducted clinical trials in cirrhotic patients in NASH. And really we see that what is the highlight and what is the summary? A, very little response, but B, variable inclusion criteria, variable endpoint definitions, and minimal success. Potentially the only success comes with the FGF21s, but as I'll later mention in my talk, FGF21s are targeted at compensated cirrhotic patients. And what are we really bothered about? We are worried about major adverse liver-related outcomes, overt hepatic encephalitis or encephalopathy, overt ascites, variceal bleeding, and of course development of HCC. We are hepatologists, we see these patients, and we struggle with these patients. So in this very nice review, I've kind of divided the spectrum of patients, and I think of this a bit differently. Because on the left side, you have patients who are asymptomatic, presenting with incidentally detected hepatic steatosis, raised liver enzymes, or screening of at-risk patients, patients who are essentially asymptomatic unless we go looking for them. But the patients who are really suffering are these patients, patients who have variceal bleeding, patients who have ascites, patients who have encephalopathy, patients who are struggling, and these are the patients where there are no options. And what is more interesting is that all the current drug targets have been approved for stage 2, stage 3 fatty liver disease. And this is very early in the disease where we're seeing asymptomatic patients. And this is a major problem. And some of the reasons why, and of course, me being critical, because there's a much larger number of patients, a huge potential profit for drug companies in this space because there are a larger number of patients and it's less challenging to do therapeutics development. So what I'm trying to highlight firstly is that we are not targeting our patients who are really suffering. And this is not a disease like hepatitis B or hepatitis C where the same drug can be used across the spectrum of disease. The second thing, we take patients with stage 4 liver disease. But really, stage 4 disease is a huge heterogeneous basket. We have patients with mild portal hypertension, patients with clinically significant portal hypertension with no gastroesophageal varices. We have patients with gastroesophageal varices, and this is generally determined by the HVPG. And we have patients with higher HVPG with worse outcomes. Yet, what do? We lump them all in one basket as F4 fibrosis. So I will touch on this later. Secondly, we'll talk about challenges in understanding cirrhosis from a MASH viewpoint. So I've summarized our understanding of cirrhosis. So if we look through our general understanding of cirrhosis, I've highlighted a lot of the studies that we generally get our acceptance of cirrhosis, the trajectories, and the prognosis from. And what is the major failing? A lot of these studies are either alcohol biased or hepatitis C biased. And you can see half the studies didn't even define MESL. They didn't even have NAFL back then. They just called it other or cryptogenic liver disease. And you can see, while we have very good data in terms of varices, prognostication based on the presence of varices, the reality is the prevalence of MESL patients in these cohorts was very, very low. The second thing is then we started looking at portal hypertension and clinically significant portal hypertension. Now, only 2 studies give us the prognostic value, and these are data from randomized clinical trials following up these patients, the simtuzumab and the selonsertib studies. So really what we see is that our understanding of the cirrhosis is, if you can see my viewpoint, that if I believe that cirrhosis from MASH is different from cirrhosis from other etiologies, then we are extrapolating wrongly. Then what is our other data? And this study by Dr. Arun Sanyal, who's my mentor and who's probably going to kill me because I'm going to highlight some flaws in the study. So, but really what I'm going to bring up is that while we look at this data, really it's very intriguing to me that the stage 3 fibrosis had a higher rate of HCC than the stage 4 fibrosis. And this actually potentially may be due to misclassification on the liver biopsies. The other thing is the prevalence of liver cirrhosis, or the proportion of liver cirrhosis was generally low. So we generally find that we are lacking global cohorts of NASH cirrhosis, and secondly, of all the cohorts of fatty liver disease, MASH, a very small proportion of them are cirrhotic. So what we decided to do, we set up a cohort. This is a global cohort. Some of the contributors are around. We actually just set this up in ASLD last year. Our first few manuscripts are coming out, and we do see we have a number of individuals from around the world and primarily based in Asia Pacific. So what are our cohort characteristics? 5,302 patients with 8,000 patients planned for version 2, of which almost half are MESL patients, because we have a very MESL biased way of looking at things. Of course, surprisingly, for a generally Asia-Pacific cohort, we have quite a low hepatitis B prevalence. And we want to look at trajectories of disease and redefine how MESL happens. So our first study looking at this is, of course, my biggest pet peeve about the MEL score in MESL-D. And what we can see is that while other etiologies, a higher MEL score portended worse outcomes, if I can show this here. You can see that the outcomes are actually desynchronous with MESL-D, emphasizing the point that the MEL score as an allocation score is not good for patients with end-stage liver disease from MESL. This is our next study looking at what we call multi-state modeling effects, and we will look to doing this based on etiology-specific considerations. So this is our answer to global cohorts and the lack of understanding of the disease. Secondly, challenges in mapping our molecular understanding of disease pathobiology. So our molecular deconvolution has been based on histology. So firstly, we have taken F3 and F4. We always, and I no offense to the people who conducted this study, this group from the litmus is really excellent. But there are limitations when it comes to cirrhosis. Firstly, we lump every cirrhotic under F4. But you and I know one patient may come in asymptomatic, get a liver biopsy, and you figure out their F4. Another one may come in vomiting blood. And another one is a transplant patient who needs a transplant, and the explant is cirrhotic. Now, all these 3 patients have hugely different presentations, but we lump them all together. The second thing is we look at the disease, and this must be, my view of this is because a lot of our scientists have very cancer training, where we look at the stage-based classification as ordinal or categorical. But really, metabolic disease is a continuous disease. And so why are we doing stage-to-stage comparisons, F3 to F4, F2 to F3, when we are truly looking at a continuous disease? So we should not be using a chi-squared test, but a t-test, if you get what I'm saying statistically. So even from my own data, we also make this mistake, or we also say this. And what do we see? We also do stage-to-stage comparisons. And what do we find with stage-to-stage comparisons? We generally find when you look at stage 4, that you generally get activation of hepatic stellate cells, fibrogenic programs. But really, even my medical student can tell me this. This is what I expect to see in cirrhosis. So how am I going to target etiology and disease if all I'm looking at is an end stage of cirrhosis and fibrosis? So this is our group's response to that. We did a stage-independent transcriptomic pseudo-time trajectory of the disease. So what we wanted to see is if we ignore histology and we map out the transcriptomic transcriptomics, then what is the trajectory of the disease? And then we define different trajectories. A trajectory of gene expression that goes down, that goes up, that is N-shaped, that is U-shaped, and gives us much relevance to the data. I will touch on this later, and these are the two ideas that we're looking at, that we want to look stage independent. But key point is I want to talk about this transition here. The disease progresses and there's a sharp transition point. And we look at a lot of the genes that make this turn at the sharp transition point that give us a better understanding of what pushes the patient forward into cirrhosis and fibrosis. Next, we will talk about endothelial dysfunction. So this is our study. This was done by one of my medical students. Now she's a junior doctor. Very a nice study. This is a study that I personally am very vested in because we demonstrated that the burden of portal hypertension is greater in MASH. I am a transplant hepatologist. I see a lot of these patients with low MEL scores that we are scoping that come in for recurrent ascites, but they haven't met MEL thresholds for transplant. I know once a week, every other week, we're doing a scope for a complex variceal bleeder. We're struggling. Our patients are struggling. But what is happening is we are not allocating them the correct scores. So what I'm trying to allude to is MASH cirrhosis is a very portal hypertension forward disease. And these patients have a longer wait time and a higher wait list mortality. So I summarize the data to say that these patients stay around longer on transplant wait lists, have a higher burden of portal hypertension, and really they only peak into that decompensation when you see the creatinine rising. Now, what do we see, and what has other literature showed us about this? That decompensation occurs at a lower HVPG in MASH patients. So when we compare Hep C to MASH patients, we realize that the HVPG gradient is lower. But I want to remind everyone of a very important concept. HVPG measures post-sinusoidal portal hypertension, not pre-sinusoidal portal hypertension. So when this is correlated with direct portal pressure measurements, we see that there's actually a dysynchrony, and the direct portal pressure is higher than the wedge hepatic pressure. So these patients may potentially be having a pre-sinusoidal component. And what correlates with the portal hypertension development? It is just the steatosis. While we all know the literature that says fibrosis and only fibrosis correlates to poor outcomes, the reality is the steatosis correlates to the portal hypertension. So what I'm trying to allude to, I can only show this on one diagram, is our traditional understanding of cirrhosis is due to post-sinusoidal portal hypertension, this part over here. But what I am trying to allude to is that there's a possibility that instead of these fibers here, at these blue lines, what you see in the sinusoids, the pre-sinusoidal component, is where the dysfunction is happening. And how can we understand this? And this pre-sinusoidal component, because of channels and venting. And I'll go through a hypothesis by Ian Wanless that really describes this and can attribute this perfectly. And so what it is, have we put the cart before the horse? Do we think that the patient develops fibrotic nodules that then compress on the sinusoids that then drives portal hypertension? Of course, there's a diastolic dysfunction component coming from the heart to provide a post-hepatic portal hypertensive component. But what potentially can we see? At the first part, we see hepatocyte injury with adjacent endothelial reaction and injury. And secondly, subendothelial edema and luminal impingement. And this is in our pre-sinusoidal beds. And then after that, arterial hyperemia and localized compartment syndrome. And then finally, the development of open parenchymal extinction lesions and closed parenchymal extinction lesions. Why is this important? Because this vascular extinction can drive fibrosis formation and this coalescence of the parenchymal extinction lesions. So this is what I allude to. Have we put the cart before the horse? So we looked at our data in this. So this is our electron microscopy data as well as our single cell data. And what did we see? Looking early in the trajectories, we saw de-differentiation of LSEX to MAVEX. CD34, PLVAP positive, and CD31 high. So basically, what this alludes to is that LSEX are becoming dysfunctional early in the disease, corroborating this hypothesis. Then we looked at our spatial transcriptomic data. can I please ask everyone not to take a photo of this slide because we're pending publication of this. So really what we have is we see NASH emergent niches that increase as the disease progresses. What do I mean? To explain it simply, because I never used to understand molecular techniques, where there's something happening, there must be two naughty friends playing together. And we want to see, so we're not looking at fibrosis. The yellow parts are not fibrosis. What we're looking at is areas where what we call next neighborhood clustering, where the two naughty friends are coming together and increasing in their prevalence of these two naughty friends as much as possible. And we see a disease progression in the disease as that we take the disease over time. So then we go and see what are these two naughty friends. And we see CD31 and CD34. So in yellow is increase, in blue is decrease. This is from our spatial transcriptomic data. And the other interacting partner are the macrophages. And we see a very low, we see increased T regulatory cells as well as the granzyme, a reduction in the granzyme positive T killer cells. So really we're seeing an immune modulation that is interacting with the endothelium early in the disease and changing, alluding to our hypothesis. We have a lot more mechanistic work ongoing, but this is what my lab is looking at. Now, looking at the mouse data, when we look, this is from one of my collaborators, Ram Das Gupta, I think some of you may know him. When we looked at the dedifferentiated hepatocytes, what we noticed is that their key reprogramming was vascular reprogramming. And when we looked at, so we looked at the endothelial cells, and what we see is the same thing, dysfunctional endothelial cells as the disease progresses. So really, I think this hypothesis of endothelial dysfunction, and it is a systemic endothelial disorder. Metabolic diseases are systemic endothelial disorders. And we're seeing this early endothelial dysfunction in the LSECs that are driving into progressive disease. Next, I switched totally to bile acids, which was actually my PhD work. So bile acids and the role of bile acids. So this was my PhD publication where we demonstrated the increase of secondary bile acids and keto bile acids in the disease. And we corroborated this in 2 global clinical trials from the placebo group as well as the pre-treatment group. And this showed that we were in the right direction with an increase in secondary bile acids and keto bile acids as the disease progresses. But when you look at microbiome and bile acid data, it's always association. What comes first? Is the microbiome driving the bile acid and the toxicity? Is the bile acid driving the we don't know, because associative data is just associative data. So we developed, so this is from a very talented postdoc in my lab who developed an in vitro triculture system looking at Kupffer cells, hepatocytes, and stellate cells in a combined in vitro system that mirrors the space of these and the spaces that we see. So what we did is we fat treated with this, and we wanted to see the effects of bile acids. And what we see is, firstly, in a cytotoxicity assay, deoxycholic acid, our key secondary bile acid, appears to be the most toxic bile acid to IHEP cells in a fat milieu. So in the right direction, corroborating what we observed clinically. Then we looked at our gene expression, and we noticed that there was evidence of lipotoxicity, quite significantly increased lipotoxicity. If you look at the gene expression, you can see PPAR gamma and SREBP2. So really lipotoxicity from deoxycholic acid. Now I'm going to take you through this a little bit slowly. So what we saw is our gene expression markers in IHEP cells. We see dose-dependent upregulation of FXR, concomitant downregulation of CYP7A1 and bile salt excretory proteins. CYP27A1, the alternative pathway, was not significantly altered, and dose-dependent upregulation in PPAR gamma without any effects of PPAR alpha. So for my friends who do not like molecular work, the summary, this alludes to lipogenic stress and steatosis progression. So then we look at our stellate cells, our IHSCs, and what do we see? Upregulation of collagen 1A and collagen 3A and TIMP, as well as increase in PPAR alpha, but no significant alterations of PPAR gamma. And what do we know? This pattern is associated with stellate cell activation. So we do know that and I'll come to the summary of all of this, but our immunostaining shows increased steatosis. Not only do we see steatosis with deoxycholic acid, but if you can see, the type of steatosis is very small. So this is microsteatosis that we see in the disease. A little bit interesting. But we see microsteatosis with deoxycholic acid treatment. And then when we stain for fibrosis, we see with fat and deoxycholic acid, we see increased fibrosis. So what am I alluding to? The fact that bile acids, especially secondary bile acids, drive lipogenic stress, inflammation, and fibrogenesis, if we can accept this. So then we started thinking that the bile acids were coming exogenously. And everyone who looks at bile acids will go to the gut microbiome, because the gut microbiome is the huge reservoir of the homeostasis of bile acids. But what we found was very interesting, that it is actually the steatosis. So what do we see? When we looked at, and remember I drew the trajectory, and so this is how we use the trajectory. And so we use this looking at the trajectory, and we notice that while FXR went up, one would expect SHP to go up, but paradoxically, SHP goes down. And then one would expect BSEP to go up, but again, paradoxically, it goes down. And finally, one would expect NTCP to go down, but it goes up. So there is dysfunctional bile salt transport. And what this is not our data, this is data that has actually previously been published, but this actually demonstrates, and if you can see, BSEP is in green, the bile salt excretory protein, and CD13 is the canalicular membrane marker. And what you can see is that there are bile transporters are mislocalized in MASH patients. You can say the cells have lost their polarity and BSEP has come in. So we looked at this from our data. So this is our RNA-seq data. And again, this is not random bioinformatics clustering. I have a lot of arguments with my bioinformatics because I believe that bioinformatics, just like meta-analysis, is rubbish in, rubbish out. So really, I think we have to look at it with a key questioning eye. And what are we looking for? So we actually looked at our protein trafficking and cytoskeletal remodeling, because that is what it was telling us. And when we looked at that, we started noticing that our gene ontology and our thought processes, or one of our key processes, were all in cytoskeletal remodeling and protein trafficking dysfunction. And you can see the changes that we see in the genes. And again, I alluded to not the progressively down and the progressively up, but the loop up. And we are seeing this with steatosis. So the early changes that we are seeing in steatosis almost primes the field. So then what happened is that, we replicated this in our cell culture models, and what we started seeing this was that the steatosis induction was the one that triggered actin cytoskeletal remodeling. And you can see this as, this is our high-resolution confocal microscopy, that as the lipid enters, you're seeing actin disruption. In red is the actin. I thought the video was the easiest way to show it. Yeah. And when we, if you look at this picture, basically when in our IHAP cells without fat, you see that the bile in green is the bile. It localizes at the bile canaliculi. If you can see this, a canaliculi membrane. But here it's intracellular. And when we calculate the ratio, there's a much greater ratio of intracellular bile to as the disease progresses, as the steatosis progresses. So what does all of this mean? I'm a practical person. So what does this mean practically? Our hypothesis is that the steatosis causes actin remodeling. This reduces the cortical actin tension. It reduces protein trafficking, causes bile dysregulation. And the bile dysregulation, driven by the steatosis, not by the microbiome, drives the lipotoxicity and the fatty liver disease. So this is where we are for those, and we are in ways to find a therapeutic way to alter this story. Now I come to the other issues. So what are the other issues in the disease? And these I will talk. And I don't really have slides for this. So firstly, I feel that, and these are my own views. Firstly, I feel that the industry drives the narrative in therapeutics in this disease space because of profit margins, because of how tests are conducted. And I feel that this is not the right way to do things, that we have to do things from the patients that have the greatest need first. So while I do not want to say ignore the F2, F3 patients and really retreat the F2, F3 patients, we're going to prevent a lot of disease. But we are still suffering from a huge burden of the disease. Our care pathways are still not ready to get the correct patients to us to treatment. Screening rates are still exceedingly low. Secondly, I talk about experts with a disease focus on early stage, and I'm going to be a bit controversial here. Being a disease expert takes time, and you need to travel for conferences, give talks, attend industry meetings, and the reality is that this leads you to manage F2, F3 patients because they're simple and easy to manage. The decompensated cirrhotic patient needs constant attention, recurrent ascites. He's calling you up all the time. As my patient always says, hey, my tummy gonna burst already. Yeah. So, I mean, these are the issues that we see. And you're coming back in the middle of the night for variceal bleeding. So I have a viewpoint that if you are focusing on this disease, you need to be knee-deep in patients, swimming in ascites and drowning in variceal blood before, and then you will understand because you are fighting and struggling for this segment of patients. The next thing I say, I feel that we need science that needs clinical relevance. Again, these are all my viewpoints. That the science, if we just take a bioinformatic profile and throw it, and we do clustering, yes, we're going to get clusters and going to get variant and potentially even high impact manuscripts. But are we going to find targets that are truly changing the disease? Then we need consensus development on endpoints in cirrhosis and decompensated disease, driven by data that we are pushing out. And I think finally I've said a systematic push for development of validated surrogate endpoints and reasonably likely surrogate endpoints in cirrhosis and decompensated disease. I think these are the keys. Because we don't understand the trajectory, we can't come up with these surrogate endpoints. With that, as a typical Asian, I now have to come to my long acknowledgement slide. I asked Grace for permission to give a very long acknowledgement series. So firstly, I think to my two mentors, Professor Dan Yok Yang and Professor Arun Sanyal, who really have put a lot of passion in the work that I do and who are never afraid to have an argument with me and are always open to having arguments about the disease and whether what I'm doing is total rubbish or not. So I'm very grateful to them, especially for Professor Dan, who's given me the time and the space to grow in this. Secondly, to my gastro colleagues. I think for those of you who know, this photo is actually 10 years old, but this is the community that I grew up in, the community that allowed me to develop as a hepatologist, as a transplant hepatologist. Yes, I love the division now, but these are the guys who actually groomed me and trained me. You can see I'm the guy hiding at the back pretending to be tall. Daniel is also pretending to be tall somewhere in there. So really, I think these are the guys I remember very fondly. And I think finally, I want to bring up, this is our team. And I think for the guys on top, these are our hepatologists who I think have given me the privilege of being involved in their training. And I'm very, very proud of them. I don't say it enough, and this may be the only time I've ever said that I'm proud of them. But the four of them on the top are really amazing clinicians and really driving the field and progressing as academic clinicians. Finally, at the bottom are my three partners in crime, Daniel, Cheng Han, and Nicholas Sin, who I joke spend half their time trying to keep me out of jail and doing something wrong. So, no, I just kid. They make sure that we do everything correctly, our statistics is correct, and Daniel has been a friend of mine since we were in high school. So really, I think it's a very important community to me. Finally, I think most importantly to me is my family. And I think being a clinician scientist with a very huge focus on patients has taken me away a lot from my family. And I'm really very, very grateful to my family. I always say I have an amazing wife that lets me do everything. She lets me be me. And I'm really very grateful for that. With that, thank you.
Thank you, Mark. That was outstanding. It's not an emerging leader. She is already a leader. And I would like to just highlight two important points. One, of course, is the triculture system that you have shown, which was beautiful, and spatial transcriptomics, but also the fact that intracellular bile acids can actually be progressive. There are many questions in my own mind, and I'm sure there are many in the minds of my co-chair and the audience, but in the interest of time, we would probably be restrained and not have questions. But I would like all of you to have another round of applause for Mark. And congratulations for the outstanding work.
Thank you so much.
Very nice seeing you. I know you have to continue another session.
Yes, correct. Yeah.